Hello, everybody. Thank you very much for joining us for this PAHCOM and ICD-Logic partnership webinar, Seize the Power of Clinical Documentation Guidance While You Learn ICD-10. We know that ICD-10 is a hot topic right now, and it's very important, of course, for a number of reasons, and we'll discuss many of those throughout today's webinar. And we're really grateful for you making time to be educated and informed and improve your practices out there across the country. So thank you for making this a priority. It's my pleasure and honor to introduce Monique Fayad. She's the CEO and founder of ICDLogic, a healthcare technology company focused on clinical documentation innovation. As a former VP of e-products and business development at Elsevier Health Sciences, the world's largest healthcare publisher, she conceived, built, and launched 3 major information-driven healthcare solutions for clinical markets, including CardioSource and Oncology Stat. From 2010 to 2012, Monique directed corporate strategy and e-solution development for HC Pro, a leading U.S. healthcare regulatory information and education provider focused on revenue cycle, clinical documentation improvement, and ICD-10 education. Monique has a degree in marketing cum laude from Chestnutville College and an MBA from the Leonard N. Stern School of Business at NYU. Please join me in welcoming Monique Fayad, who will introduce her co-presenter, Dr. Wilbur Lowe. Monique?
Hi, good afternoon, everyone. Thank you very much, Karen, for that introduction, and welcome everyone to our webinar today about seizing the documentation of clinical documentation guidance. Actually, I am going to let Dr. Lowe give his own brief introduction, but I just again wanted to welcome everyone at today's webinar, aiming at showing clinicians and administrative staff how they can learn ICD-10 while they work and sharpen their clinical documentation skills at the same time. So as Karen mentioned, I am Monique Fayad, CEO and co-founder of ICDLogic. And Will, why don't you tell us a little bit about yourself, Dr. Lowe?
Sure. Thank you so much, Monique. I'm Dr. Wilbur Lowe, a CDI educator and pathologist, and I'm really looking forward to this webinar because together we're going to connect the dots to help the audience understand the negative impacts of poorly coded patients and how easy it is to seize the power of good clinical documentation.
Great. And we'll also demonstrate an innovative and easy-to-use tool, which is called Cypher, which has been developed by ICDLogic, that helps improve clinical documentation while teaching ICD-10 concurrent with care. So let me move on to the next slide. A week ago today, actually, President Obama signed into law the Medicare Access and Chip Reauthorization Act of 2015 that is going to change the way that Medicare will pay doctors. Now, this is probably more well known as the Doc Fix bill that we all heard about, and the legislation requires or creates a new system for reimbursing doctors that will gradually tie payments to the quality of care. Many expected this bill to be the vehicle for another ICD-10 delay, but that didn't happen. So we'll start our webinar by talking about how critical it is to begin preparing for ICD-10 now, if you haven't already begun. And then we'll shift to talking about the impacts of chronic illness in America because chronically ill patients are requiring more and more involved care and more cost and resources. And if you're moving to a system tied to quality of care, it's critical that the patient record will reflect that. The more specific ICD-10 code set is thought by many to be the way or the method for documenting complexity of care to help track that quality of care. And then Dr. Lowe will present several case scenarios that illustrate nuances in outpatient coding, discussing the concept of severity of illness to review some interesting research about the unintended consequences of poor documentation. And then he'll share his perspective on some of the root causes of such poor documentation. I'll wrap things up by showing how you can use clinical documentation improvement software to maximize your advantage, and as I show and document a few chronic illnesses like asthma, diabetes, and chronic kidney disease. And then lastly, Dr. Lowe and I will present some strategies to help sharpen clinical documentation skills. So at the conclusion, we'll address any questions that you may have. So right now what I'm showing you here on the slide is a planning chart from CMS, Centers for Medicare and Medicaid's Road to 10 portal, roadto10.org, and this timeline shows the suggested ICD-10 preparedness timeline for small practices. Now, I'd like to draw your attention to a few important aspects of this preparation timeline that are depicted by the green arrows and boxes that we've added to the chart. So according to CMS, small provider groups of under 5 physicians should be well into the training phase of ICD-10 today, as shown at the top of this chart. And also, you should be, according to CMS, small provider groups of under 5 physicians should be doing this concurrent with training and testing and needing to test your systems and processes. Let's look at the green arrows a second. CMS is advising physicians that clinical documentation training is essential in I-10 preparation, and that providers should be updating their documentation processes right now. So if there's one takeaway from today's webinar, it should be this. Regardless of what code system you're using, ICD-9 or ICD-10, patient records must have the clinical documentation to support the diagnosis code that has been assigned, or that code will be questioned and potentially denied. And as you'll soon see, research already suggests that clinicians are not doing a very good job of clinical documentation even today in ICD-9. Moving on. Interestingly, just last Friday, I listened in on a Florida Blue Cross presentation where it was actually a webinar that they do about ICD-10 every month, and they presented the initial statistics from a research project they're currently fielding to understand preparedness of providers for ICD-10. Now, it's just been the first 2 weeks of the survey, but they already had 281 respondents, the majority of which were small physician practices, 72%. Of that, 22% of the respondents said that they have not yet started to prepare for ICD-10, and another 14% said they'd like to start, but they have no idea where to begin. So that means that 36% of the small provider market is currently unprepared for ICD-10 today, with less than 6 months to the October 1st cutover date, which is concerning and alarming. But it doesn't mean that it will be impossible to move them to preparedness, and hopefully webinars and education and tools like Cypher will help move the needle and make this whole lot easier. So this survey on Florida Blue Cross will remain open until the end of this month, but these initial indications are definitely eye-opening. So just a quick overview of the population demographics and healthcare of the United States population. As you all know, America is home to more than 320 million people, and the numbers that are driving our growth and the changing demographics of our growth are quite interesting. Now, this chart is a few years old. I think it's from 2010, but it helps visualize the current distribution of Americans based on age brackets. And as you can see by the arrows on the right, about 13% of the United States population at the top are currently above age 65 or 65 and older. Now, the chart helps us see that every 10 years, the tier of those over 65 is growing larger. And in fact, over the next 16 years, 10,000 baby boomers will turn 65 every day. So America is an aging population. It's living longer, but at a great burden to our healthcare system because chronic conditions and multiple chronic conditions and comorbidities are steadily becoming the norm. Also poor choices in diet and personal risk factors and behaviors relating to exercise and smoking and drinking are taking a toll on our population as well. Sadly, in 2012, half of all adults had one or more chronic diseases and 25% had 2 or more. 7 of the top 10 causes of death are chronic diseases, and 2, heart disease and cancer, account for nearly half of all deaths in America. So comorbidities are defined as a combination of a patient of 2 or more chronic diseases or disorders, which are pathogenically related to each other or coexisting in a single patient independent of each disease's activity in that patient. But many comorbidities are never documented inside the patient records. So let's talk about how treatment of chronic conditions burdens our healthcare system and how our better documentation is really essential to improving outcomes. But before we do this, Dr. Lowe is going to provide us with an overview of documentation, coding, and reimbursement in the ambulatory setting. So with that, I'll turn it over to you, Dr. Lowe.
Yeah, thank you so much, Monique. Coding can be confusing, and when not done properly, clinicians are not fairly reimbursed for their work. It is estimated that last year, physicians left over $1.5 billion unclaimed for services they legitimately rendered. The Healthcare Common Procedure Coding System, HCPCS Level 1 codes, are referred to as the CPT-4 codes and are maintained and updated by the American Medical Association, whereas the HCPCS Level 2 codes are non-CPT-4 codes and include codes for ambulance services, surgical supplies, durable medical equipment, chemotherapy drugs, vision, and hearing services. CPT-4, the current procedure terminology, 4th edition, is used by physicians to report services and procedures performed in the inpatient and outpatient setting, as well as by ambulatory care facilities to report outpatient services and procedures. Use of these CPT-4 codes, if linked to the proper ICD-9 or ICD-10 diagnosis codes, will lead to proper reimbursement for services and procedures. The International Classification of Disease Codes, or ICD, both 9th and 10th edition, are created by the World Health Organization and then modified by each country that adopts them. So ICD-10 in Canada is slightly different than ICD-10 in America. ICD-9 and ICD-10 diagnosis and procedure codes are maintained by 4 cooperating parties comprised of Centers for Medicare and Medicaid Services, CMS, National Center for Health Statistics, NCHS, American Health Information Management Association, AHIMA, and the American Hospital Association, AHA. CPT-4 Category 1 codes are referred to as the permanent codes and include 6 sections: evaluation management, known as EM codes, anesthesia, surgery, radiology, pathology and laboratory, and medicine. EM codes are used for the physician's time and expertise. Most of the EM categories and subcategories are further divided into 3 to 5 levels of service. A Level 1 EM service meets the criteria for a problem-focused history and examination with straightforward medical decision-making, whereas a Level 5 EM service meets the criteria for a comprehensive history and examination with high-complexity medical decision-making. Now, here's a simple case scenario. A physician performs an EKG and a series of lab tests to rule out an acute myocardial infarction, but makes an entry of chest pain instead of acute myocardial infarction in the patient's record. If the physician doesn't respond to a coding query, the coder must assign the diagnosis code for chest pain. In the previous slide, I discussed EM codes for CPT-4 coding. In this scenario, the eligible provider rate in Philadelphia for a Level 2 emergency department consultation is $75 for chest pain, compared to a Level 5 emergency department consultation of $204 for an acute myocardial infarction. Clearly, incomplete or improper documentation can adversely impact treatment and reimbursement for facilities and providers. Clinicians rely on information to provide proper treatment. If information is missing in a patient's medical record, the clinician will be required to waste precious time to locate the information, and this may affect the quality of patient care. A sick patient requires more resources. If a clinician does not properly document the patient's condition, the patient may appear less sick, and the clinician may be questioned for over-utilizing resources. The clinical language does not translate directly into the coding vocabulary. Significant gaps exist between the clinician's knowledge of disease processes and the novice coder's ability to navigate through the chart and abstract the proper diagnosis and procedure codes. Disconnects between a clinician and coder may lead to claim denials and audits if the coder inadvertently assigns diagnosis codes that are not linked to the procedure codes. For instance, a clinician performs an angiography to detect a possible pulmonary embolus in the left pulmonary artery, but the patient is also being treated for a urinary tract infection. If the novice coder assumes that the angiography is for the urinary tract infection and does not capture the diagnosis of pulmonary embolus, the insurance claim and payment will be denied. I want to take a moment to discuss the Resource-Based Relative Value Scale, RBRVS, which is the federal government's payment system for physicians. By creating the RBRVS system, the rates of reimbursement for services of general practitioners for office visits and consultations were increased to rates comparable to specialists. RBRVS is a complex reimbursement concept that classifies physician services based on the setting, the skill and training required to perform the services, the time, and the risk involved. RBRVS is based on the codes listed in CPT-4. The Medicare Physician Provider Fee Schedule formula for RBRVS is based on the RVUs, GPCI, and CF for each CPT-4 code. Relative value units, RVUs, are based on physician work, practice expense, and malpractice, respectively. Geographic Practice Cost Index, GPCI, is an adjustment for variation due to location. This means that a colonoscopy will be more expensive in San Francisco than in Pittsburgh. The conversion factor, CF, is a multiplier based on the Sustainable Growth Rate System established by the Centers for Medicare and Medicaid Services. In the place of the Sustainable Growth Rate formula, the new Medicare legislation that President Obama signed will involve a steady 0.5% increase in Medicare payments to doctors every year until 2019. Then a different system where doctors are financially rewarded or penalized based on their performance would begin. In short, complex CPT-4 procedures will have higher values for RVUs and GPCI. Multiplying these values by the conversion factor will lead to increased physician reimbursement. An effective clinical documentation improvement program will lead to proper documentation of diagnosis and procedures. The ICD-9 and ICD-10 diagnosis codes will justify the medical necessity of the CPT-4 procedure codes and will result in appropriate reimbursement for the physician. Let's switch from codes to the actual diseases or conditions represented by the diagnosis codes. In 2010, Health and Human Services became so alarmed by the prevalence of chronic conditions that it started an initiative to build a 4-part strategic framework to address this issue. In the blue font, the third part of the framework involves equipping healthcare providers with tools, information, and other interventions. In 2012, 8 planks were established to support the framework. Plank number 5, integrating MCC into clinical practice guidelines, is particularly germane to our discussion and is a challenging task. Also, I want to point out that MCC can stand for multiple chronic conditions, as well as for major complications and comorbidities, which relates to inpatient reimbursement. This chart is one of the tools made available through the HHS Multiple Chronic Conditions Initiative. It is part of a Medicare beneficiaries chart book and interactive website that is frequently updated and allows all providers to follow the progression of chronic conditions at the state and national levels. In this chart, the top 15 chronic conditions are listed by prevalence. It's not a pretty picture. In fact, it's frightening. Medicare currently covers 54 million Americans, so data from 2012 would represent approximately 49 million Americans. And this chart does not represent chronic conditions of the 69 million Medicaid enrollees or of all other Americans under age 65 not insured by Medicare or Medicaid. As indicated by the data highlights in the lower right portion of the slide, approximately 6 in 10 Medicare beneficiaries have high blood pressure. Now that's nearly 30 million people. To put that in perspective, 30 million is about the size of the entire population of Canada. 45% of Medicare beneficiaries have high cholesterol, and having 28% of beneficiaries with diabetes is particularly troubling since it is challenging to treat the complications of diabetes. You are the first person to join the meeting. Please stand by. As beneficiaries age, they suffer from more chronic conditions. Unfortunately, poor choices in diet and exercise early in life lead to problems later in life. I want to focus on the bars enclosed in the red box in the far right column. According to the purple bar, 25% of the beneficiaries over the age of 85 suffer from 6 or more chronic conditions. But as you're about to see in just a few minutes, this data is only as good as the documentation of these conditions in the patient's chart. Evidence is mounting that codes are not assigned for many chronic conditions in the patient's charts, regardless of age. As one might expect, patients with more chronic conditions have a greater chance of being hospitalized. Each column represents the number of conditions from 0 to 1 to 6 or more. And note the purple boxes at the top of each column. On the far right column, 16% of beneficiaries suffering from 6 or more conditions were hospitalized 3 or more times in 1 year. Looking once again at the purple boxes, 27% of beneficiaries with 6 or more conditions had 3 or more visits to the ER. Healthcare reform has pinpointed hospital readmissions as a key area for improving coordination of care and achieving potential savings. The CMS Hospital Readmissions Reduction Program has selected acute myocardial infarction, heart failure, and pneumonia as target areas for the Medicare population. CMS chose these conditions in part based on their high prevalence and their associated high costs for total admissions and readmissions among Medicare beneficiaries. Next year, CMS will target additional conditions that represent high volume and cost. As you realize, emergency rooms are hectic, and it's very challenging to balance patient care and paperwork. So I suspect that these numbers might be underreported, and the number of people with multiple chronic conditions, whether 0 to 1 or 6 or more, is greater in each of the columns shown on this chart. Obviously, healthcare for sicker patients costs more money. So again, it is not surprising that patients with 4 or more chronic conditions represent 37% of the beneficiaries, yet account for 74% of Medicare spending. In 2011, Medicare patients accounted for 56% of all readmissions and cost to taxpayers $4.3 billion in hospital cost. This is staggering. Let's look at another ambulatory case scenario. A patient visits a physician's office and complains of low back pain. The physician makes a diagnosis of nephrolithiasis, the medical term for a kidney stone, and performs an extracorporeal shock wave lithotripsy procedure known as ESWL, which uses shock waves to break apart the kidney stone. If the physician documents low back pain instead of nephrolithiasis in the patient's chart, what is the consequence? Low back pain will not justify the medical necessity of an ESWL. Instead, the insurance carrier may decide to pay for the injection of a painkiller rather than the ESWL procedure. With respect to RVS payments made to the physician, this makes a huge difference. In Philadelphia, the physician will be paid $27 for the injection compared to $781 for the ESWL. With respect to the ambulatory payment classification, APC payment made to the facility, the difference is even more striking. According to the Centers for Medicare and Medicaid Services, the facility will be paid $54 for the injection assigned to APC 0437, compared to $3,160 $113 for the ESWL assigned to APC 0163. Essentially, in this scenario, improper documentation of a non-specific diagnosis, such as low back pain, as opposed to nephrolithiasis, will result in the physician and the ambulatory care facility being shortchanged $754 and $3,059, respectively. Beyond reimbursement, however, documentation of complications and comorbidities helps to present a clearer picture in population health management. Physicians are not that different from other workers when it comes to on-the-job paperwork. For many years, there were no standards governing physician notes in the patient's chart or the documentation of chronic conditions and comorbidities. This led to a wide variation in the quality of physician notes. Now, even as our work becomes computerized, there are thousands of different EHR and practice management software programs, and each captures chronic conditions in a slightly different way. Numerous research studies show that problem list can be an Achilles heel for many software vendors. I wasn't surprised by the charts that I'm about to share with you next, but I certainly was shocked to see the pivotal role of good documentation in quality patient care and better allocation of healthcare resources. In a quest to better understand the scale and implications of uncoated patients, a team of researchers at Humedica, a data mining company now owned by Optum, sifted through data from over 4 million actively treated patients who had evidence of major chronic conditions, but who did not have any corresponding diagnosis codes on their claims or EHR problem list. Based on the evidence from lab results, notes, clinical outcomes, and prescribed medications, Humedica determined that 37% of patients with evidence of diabetes, congestive heart failure, coronary artery disease, hypertension, or dyslipidemia were not assigned diagnosis codes for one or more of these conditions. That sure caught my attention. In other words, approximately 17% of the patients in a typical medical practice are encoded for at least one major chronic condition. So if a medical practice serves 500,000 patients, about 83,000 patients are encoded for one or more chronic conditions. These findings appeared in the September 2013 issue of The Collaborative, a newsletter published by Humedica. These patients were described as relatively sick, with nearly half showing evidence of more than one chronic condition. As you might expect, uncoated patients typically have lower rates of utilization of healthcare, regardless of condition. The Humedica article suggests the rate of primary care utilization for uncoated patients can be as much as 73% lower, as seen in the green box in this chart for diabetes patients. In fact, as indicated by the green arrow, ambulatory visits at all evaluation and management levels, especially level 4 and 5 visits, are lower. However, acute care utilization among diabetic patients is higher. As seen in the pink column on the right-hand side of this chart, uncoated patients have 30% more emergency room visits, 45% more inpatient visits, and 33% longer average length of inpatient stays. This data suggests that a significant opportunity exists to identify uncoated patients to reverse the pattern of utilization of acute care and to shift toward the utilization of ambulatory care, which is focused on preventive care and is less expensive. This is a proactive versus a reactive approach. In this chart, Humedica followed newly coded patients, along with a cohort of always coded and never coded patients for 1 year. They found dramatic improvements when previously uncoded patients became newly coded across the following chronic diseases: diabetes, congestive heart failure, hypertension, dyslipidemia, or elevated cholesterol, and coronary artery disease. As you may recall from a previous chart, hypertension has a prevalence of 58% with respect to chronic conditions among Medicare beneficiaries. In this study, 68% of hypertensive patients who were newly coded experienced clinical improvement versus 50% for those always coded and 52% for those never coded. Just imagine how we could improve patient health and lower resource burdens if these diseases were coded 100% of the time. I spoke earlier about the serious complications of diabetes, which can affect multiple organs and lead to heart disease, stroke, end-stage renal disease, blindness, amputation, and conditions affecting the quality of life. This study showed that for newly coded diabetic patients, the clinical improvements were across many different measures, especially lipids and systolic and diastolic blood pressure. Improvement in hemoglobin A1C levels in newly coded diabetic patients was especially significant. The A1C levels measure the percentage of hemoglobin that is glycosylated, which refers to hemoglobin that is coated with sugar. Hemoglobin, as you realize, is a protein in red blood cells and carries oxygen. Higher A1C levels suggest poorer blood sugar control and higher risk of long-term diabetes complications. So why was there such a significant improvement in newly coded diabetic patients? Here's what the authors had to say. Quote, in year 1, utilization increased for all types of clinical services. Annual outpatient visits per patient increased from 2 to nearly 6, the same rate seen in patients that had always been coded. The PCP visit rate nearly doubled, and the rate at which they saw endocrinologists and cardiologists more than doubled. There were also increases in ER and inpatient visits. This widespread increase in utilization likely occurs as patients become more integrated into the health system or practice, and their level of care is right-sized relative to their need. In contrast, utilization decreased across the board for uncoded diabetes patients. Their use of the health system was low to start with, and it will decrease further, unquote. Now that we've seen some evidence concerning uncoded patients who become newly coded, let's take a moment to discuss the reasons why physicians don't always provide documentation of comorbidities. But first, let me use a third scenario to illustrate good versus bad documentation. Consider these two examples of documentation for the same patient with asthma. At first glance, the upper caption appears smaller than the lower caption, which suggests that it may be missing some vital information due to incomplete documentation. Upon closer examination, the lower caption indicates that the patient had status asthmaticus, as opposed to an asthma attack described in the upper caption. Status asthmaticus is a complication and comorbidity, CC, and requires increased utilization of resources and will lead to increased reimbursement for the facility. Intellectually, physicians understand the value of documentation, but because physicians do not take courses in documentation and are not formally trained in documentation, physicians approach documentation differently and with various levels of commitment. Second, it's hard to engage physicians and gain commitment if documentation is not part of the ingrained workflow, especially if it's not well understood and remains an enigma. Increased paperwork requires physicians to see more patients in less time just to keep pace with cuts in reimbursement. Physician productivity plummeted with the adoption of electronic systems, and many physicians are just plain burned out. Fourth is the antiquated query system. If physicians can have a better understanding of the correlation between proper documentation and coding, the query system would disappear. There are no baseline standards imposed on EHR and practice management systems, and many do not focus on documentation and ICD-9 or ICD-10. After 30 years, many physicians have memorized the ICD-9 codes most relevant to their patient population. Further, the media and special interest groups have done an injustice by inaccurately portraying ICD-10 and striking fear in the physician's minds. Actually, ICD-10 is an intuitive, specific code set aligned with evidence-based clinical guidelines. At this point, it is my pleasure to reintroduce Monique.
Hey, Monique, are you on mute?
Can you hear me now?
Yes.
Hello? Okay, I'm sorry about that. I guess I was muted on the console. So, as you know, Dr. Lowe, a frequent complaint that I hear from providers...
I'm hearing you on my phone. I don't know if I'm hearing you across the computer. But yes, we are. I'm sorry. Go ahead.
Okay, you hearing me okay? All right, I'll just go ahead. Dr. Lowe, are you hearing me?
Yes.
Okay, great. So why don't we go ahead? Sorry about that little technical issue. Okay, so one of the frequent complaints that I hear from providers is that the requirement for documentation to support ICD-10 coding is an unnecessary administrative burden. If we look closer at the types of documentation needed to support proper coding in ICD-10, the required documentation is really a part of good patient care. If we look at any of the following requirements to support ICD-10 coding, they are pretty straightforward. Yes, the number of codes is increasing, but for very logical reasons. As you can see with the box on the right of this chart, ICD-10 asks the clinician to note for site specificity and laterality. And just by indicating whether a condition affects a bone, muscle, or organ on the right or left side of the body accounts for 25% or 25,000 of the new ICD-10 codes. So how difficult is that? I'm going to try one thing here because I believe that my computer is also collecting my sound. Okay, can you hear me now? Dr. Lowe, can you hear me? Okay, I'm going to go ahead. All right, so let's consider the thigh bone or femur. Now, this is a very large bone in the body, and it has some very distinct features. It stands to reason that a fracture of the head of the neck of the femur may require different care than a fracture of the shaft. ICD-10 merely asks the orthopedist to explain where the fracture occurred and which leg is affected, right or left. When you think about the number of codes increasing, it's logical to see that site specificity is just part of good medicine. So ICD-10 asks the clinician to document other medical conditions and common signs and symptoms. Understanding if something is due to or manifested by can be incredibly helpful to the provision of care and also to the patient's ability to recover. And what about all these interesting codes like skis on fire and orca bites? Well, many would be surprised that a lot of these same codes and descriptions exist in ICD-9. So every time I see this cartoon, and I think it came from Relay Health, I chuckle a little bit because people characterize ICD-10 as a coding problem, but we at ICDLogic believe it's really a documentation challenge. It doesn't matter if ICD-10 happens next October or the October after that. The time to do a better job of documenting is now, as we saw with the Humedica study, because it has a big impact on patient outcomes. There are many software tools available today that can help everyone sharpen their documentation skills right now. And these are all, relatively well available and relatively inexpensive. So there's a whole generation of computer-assisted physician documentation tools that have begun to enter the market. And these will help eliminate the need for expensive training by integrating documentation into the workflow. It's a lot easier to code current with care than to try and remember something about a patient days or weeks later when a coder asks a question about that patient. Many of these software tools have custom indexes that fix the flaws in the current GEMS mappings, or government general equivalency mappings, that try to assign codes from ICD-9 to ICD-10. And some also let the clinical team dual code in both ICD-9 and ICD-10. As Dr. Lowe mentioned, many electronic health record ICD-10 solutions do a poor job of offering clinicians clinical documentation guidance, especially when it comes to documenting important complications and comorbidities. That's why we're proud of the system that we're about to show you now. It's called Cypher, and it helps you to select a condition, specify according to new requirements of ICD-10, and document additional complications and comorbidities. So let me move on. Okay, so what I'm going to do now is take you through a few scenarios with this tool that we call Cypher, and it shows you in 3 easy steps and less than 30 seconds for most conditions. It'll help you generate best-in-class documentation and dual coding for ICD-9 and ICD-10. And I'll take you through a few conditions that you see here on this slide. And what I'm going to do now is actually flip over and show you my desktop. And there might be a small delay here. We had a little bit of a delay during our run-through prior to this call. So I'm going to switch over to my desktop now. And Dr. Lowe, if you would be kind enough to tell me if you're seeing the Cypher screen. I'm seeing it now on my desktop. Dr. Lowe, are you seeing it?
Yes, I see Cypher. Okay,
great. So I'm going to go ahead and log in. Cypher, it just requires an easy username and password. I'm taken to the main Cypher login page here. This is the first page a user would see when they enter the program. And just a couple quick things about Cypher. There was a lot of time spent on the design to make it very clean and easy to use for a clinician. So that, and you don't need to know anything about coding to use it. I mean, basically just go in and utilize your clinical language. So let me go in and show you how quickly I can go in and document asthma. So I just type in asthma, and it's like a Google search, and you'll see the results of the different types of asthma that you might be looking for. So we just click on asthma. And now the program actually changes a little bit, and it provides me some clinical documentation guidance here, and it's asking me to select more specificity around the asthma and the type, the frequency, and persistence of the asthma. And these new definitions are available here just to your right. So based on this, I would just click on moderate persistent, and then it's going to ask me if there's any exacerbations or complications such as status asthmaticus in the example that Dr. Lowe mentioned earlier. And lastly, if there are any additional factors. So is there tobacco use dependent? Is there COPD, acute respiratory failure? Now, these are things that will definitely affect the patient's severity of illness and potentially reimbursement. So I click on complete diagnosis. I'm taken to a summary page that provides me the detailed ICD-10 description, as well as the ICD-10 code and the ICD-9 code or codes. As you can see here, it could be possibly have been in 2 different codes, either extrinsic or intrinsic. So now let me go back. I'll show you how I can continue to document this patient by selecting another condition. And I want to do diabetes mellitus 2. So I can just type in a shortcut here. And now, as you see, the program is actually prompting me to specify if there are complications, diabetic complications, and if multiple complications exist, to include separate documentation for each. So let's say in this case, this patient has circulatory complications, and it's going to ask me if there's any gangrene present. So again, this is just important to know because it will affect the patient's outcome. So we'll say without. Lastly, it's going to ask us to document additional factors like long-term insulin use and if there are any other comorbidities. So again, typically a diabetic patient will have multiple diabetic complications. So I'm taken to my summary page here again, and you can see that my summary has been appended with this detailed diabetes description, the insulin use, and the codes for diabetes and the Z code for insulin use. Now let me document a new patient. We'll look at chronic kidney disease, or CKD again. The system includes a lot of shortcuts and aliases. The whole goal here is to save time and to allow documentation guidance concurrent with care or shortly thereafter. So I type in CKD. It's now going to ask me to specify the stage, and it provides some of the definitions around the staging. Also is telling me to specify if the condition is due to another underlying cause because typically chronic kidney disease or kidney disease could be triggered by organ failure or diabetes or heart failure, that type of thing. So in this case, we'll say this is mild chronic kidney. Again, it's going to ask us about these underlying causes because those are important to document, and other comorbidities. If they're present, if they're not present, you just complete your diagnosis. And we're taken to your chronic kidney disease, stage 2 mild, and the ICD-10 and ICD-9 codes. What's interesting about Cypher is you can actually go in and search by a code. So if I want to go in there and I type in my ICD-9 code that I know, it'll take me through the documentation guidance needed to get to the right ICD-10 code. Because a lot of people have memorized ICD-9 codes, but this helps you go from the 9 to the 10 very, very quickly. So lastly, I'm going to show you that femur fracture example because that's the femurs are pretty complicated and there's a lot of codes associated with them. So I could type in femur fracture, or I could type in a shortcut such as FFX. And now you see something a little bit different. Actually, what we have here are called clinical filters. And the guidance is telling us to specify using the filters. So I would say, okay, it's my initial episode, laterality, the wound class. Now, if I don't know the wound class, I can again scroll down here. I have all of these definitions integrated at my fingertips. So we'll say based on this, the wound classes is 3. Alignment, displaced, and healing would not be relevant. And then I just have to go into the anatomy. So what part of that big bone was affected with this fracture? We'll say it's the head and the neck. We have to actually provide more specificity. And lastly, we're asked if there are any factors in terms of the cause and location of the injury, the blood alcohol level. So for certain injuries, depending on your state or your payer, you will be required to document the cause and location. And the system Cypher includes all of these cause and location codes. You can very easily look up, so you don't have to worry about, all those different codes that may appear new. And then also there are comorbidities such as blood loss anemia or additional fractures if this was a car accident. So I'm taken to my summary page. I have my very detailed ICD-10 description, and I have this little flag here that again just prompts me that I may need to document my cause and injury codes. I have my 7-digit ICD-10 code and my ICD-9 code. Now, if I want to go in and document the cause, I can just say add, and if this was due to a fall, it'll search through all of the fall codes. It'll say initial. It'll ask me if there's any fire involved. And so now I have my cause code. And likewise, I can go in and actually just search on location by apartment. It'll prompt me for what room. So all of those details that I need to know are included in Cypher. So you don't have to go looking anywhere for any of that information. So that's the quick overview of Cypher. And I'm going to switch back now to my slides. Okay, so I believe we're going to have to get back to the slide presentation. It may take a moment for the slides to come back up. If you can just bear with us for a moment. Okay, I believe it's loading now. Thank you everyone for your patience and staying through the entire program if you've stayed on. So it'll just take a moment to fully load. Okay, so we should be on slide 35 right now. Okay, I cannot see the slides, so I'll just speak to them, and if you can begin forwarding, that would be fine because it still appears that my screen is loading. So as Medicare is further squeezed by an aging population that lives longer and suffers from multiple chronic diseases, it's only inevitable that a seismic shift in the way physicians are compensated is going to occur. We're moving away from a volume-centered payment model that reimburses doctors based on fee-for-service with a value-centered model that is tied to outcomes. So right now, there are no repercussions or rewards for outcomes, really, but in the value-centered approach, there will be qualities, incentives, and penalties. And as Dr. Lowe mentioned, in the place of the sustainable growth rate formula, the Medicare Access and CHIP Reauthorization Act of 2015 will increase Medicare payments to doctors by 0.5% every year until 2019. Then a different system where doctors are financially rewarded or penalized based on performance will begin. And technology will take a central role in that. So how do you get prepared for the impending ICD-10 deadline of October 1st and help sharpen your clinical documentation skills inside your practice? Well, Dr. Lowe and I are going to take you through a few pointers about how you could do that. Dr. Lowe?
Thank you, Monique. Let's face it, physicians are trained to make diagnoses, not to assign codes. Physicians should ditch the code books and learn ICD-10 functionally as it pertains to the treatment of their patients. I am not a big fan of watching videos and listening to lectures about ICD-10. When there is a steep learning curve, the best way to learn is to learn while you work. That's why products like Cypher are helpful.
And practice managers should focus on the emotional drivers that a physician will respond to, not wagging fingers and preaching, but helping your physicians see if they improve their clinical documentation, they'll make positive progress in care quality. So don't make it all about the practice, make it about the patient.
The practice manager should investigate workflow tools that help physicians learn while they work. In addition to Cypher, there are other e-learning tools like Implement HIT and software tools like DocEdge and iDocument.
And also, you should take the time to create a culture inside your practice where you, as the practice manager, become the ICD-10 or CDI champion. Recognized for your leadership skills and recognizing what it means to better patient care.
Physicians should use concurrent and retrospective reviews of patient charts as a means to learn from mistakes and to reinforce best practices.
And don't forget that there's nothing like peer pressure and competition to cause some positive changes to occur. Deep down, we all want to be recognized when we do a great job. So be lavish with recognition and give lots of shout outs when another physician in the practice is documenting correctly or consistently showing very good documentation practices.
And templates are a great way to ensure that documentation is complete and consistent.
So get your tools in place now and start pilot testing them. Do not wait until September to realize that you're not prepared. And visit the Road to 10 portal to create templates for your preparation timeline. So we'd like to invite everyone on the call today who has registered to visit the ICDLogic website, schedule a demo of Cypher, and take advantage of a very limited one-time special offer for all of today's webinar registrants. If you subscribe to Cypher between now and the end of April and use the PAHCOM 10 code, which is shown here on the slide, you can get a Cypher license for just $10 a month. So this is $25 less per month than our current retail price that's posted on our website. All of today's PAHCOM webinar registrants will receive an email from us with this exclusive offer and the links to subscribe. Cypher comes with a money-back guarantee, so if you're not satisfied with Cypher for any reason, ICDLogic will refund the full cost of the subscription if you notify us in writing within 30 days of activation. Now, we'd like to thank you for listening and would be happy to answer any questions you may have. So while we were presenting, a few questions came in. One question was about the cost of Cypher, which I believe I just addressed. So normally the retail price is $35 per month per individual user. There are volume discounts available over 10 users. But for anyone on this call, we're offering a very special limited and reduced price of $10 per month if you use this promotional code PAHCOM10. So please take advantage of that because it's also a money-back guarantee if you'd like to. I do see some questions about whether or not Cypher incorporates into an EHR, and the answer to that is yes. We have built Cypher. It's a cloud-based system. It's built on an API or application programming interface architecture, so it can be accessed quickly by any system that can do a call out to the web. We do have built standard APIs so that it can integrate into your electronic health record. And we're actually actively talking to some of the major electronic health record systems now, such as Allscripts, NextGen, and others, about how we may be able to more closely integrate into their systems. So there was a question earlier on, Dr. Lowe. It was a question about rule-outs. And I think I went back to your question about the myocardial infarct rule-out. So this question stated, it's our understanding that you cannot code rule-out diagnosis. So a patient presents with chest pain and you're doing a test to rule out myocardial infarct, but is not determined, you can only code the symptoms. Please explain your comment that states you should code MI, though not determined yet.
Yes,
Could you comment
thank you
on
so
that?
much. Sure, thank you so much, Monique. This is an excellent question, and I want to revisit the case scenario. This is a person who actually had an EKG and lab test, and the clinician in the mind was thinking about or ruling out an acute myocardial infarction. But this is absolutely true. If the clinician writes down the word rule out in the actual chart, then of course, according to the official guidelines for coding and reporting, one cannot report the code for an acute myocardial infarction if you have the words rule out. But if the clinician was just thinking about the acute myocardial infarction and actually made a diagnosis and did not write the term acute myocardial infarction in the chart and wrote down chest pain instead, in that case, we are then, of course, shortchanging the clinician because in that case, the clinician spent a lot of time to make a diagnosis of an acute myocardial infarction. So it's a great question. So again, if a clinician is maybe thinking about things in his or her mind, then the rule out, of course, is in his or her mind. But if the clinician writes down rule out or any type of qualified diagnosis in the patient's chart, then of course in outpatient coding, one cannot report those conditions. And then in that case, chest pain would have been reported. But I was referring to that slide as a clinician thinking about acute myocardial infarction in his or her mind and writing down chest pain instead of the actual diagnosis of an acute myocardial infarction.
Great. Well, thank you, Dr. Lowe. I appreciate your taking time to explain that to the audience member who sent that question in. I believe we've reached our time, and I don't see any other questions coming in right now that we have not addressed. So I would like to thank everyone for taking the time to listen to Dr. Lowe and myself, and for taking time to preview a powerful clinical documentation improvement and coding tool called Cypher, and welcome you all to take advantage of this fantastic time-limited discount to PAHCOM members. So thank you very much, and have a wonderful afternoon.
Thank you very much, Dr. Lowe and Monique as well. And also thank you to the whole ICDLogic team. There are a lot of people behind the scenes making this a success, and we appreciate that. I want to say that the slides will be coming to everybody that's registered on this call in an email, so keep an eye out for that. And we'll also have a recording of the entire webinar, both the slides and the audio from the presenters, available on the PAHCOM YouTube channel. It's youtube.com/PAHCOM. That will also be in the email. And by the way, happy birthday to YouTube. I heard earlier that it's 10 years today. Wow, how time flies. And then also CEUs. I know everybody's interested in those. This webinar was approved for CEUs from PAHCOM, pre-approved, and that means that you can get those if you send an email to ceu@pahcom.com. There'll be a link in the email that we send to follow up. But if you do go ahead and send it before you get that link, please make sure that you include your name as you want it on the certificate, and make sure that you include in the subject line Cypher or ICDLogic. Either of those two will alert us to which one of the events that you're writing about, and we'll go ahead and get that CEU certificate off to you. And thank you also to everybody on the call. It's so important to make sure that that we have the right information and we're doing everything as efficiently and accurately as we can in our practices. It helps you, it helps your practice, it helps your community, your patients. So thank you very much for being proactive, and you guys have a fantastic day.